Hello everyone and welcome back to my playlist of gynecology from 10 teachers. This is Dr. Asif Lectures and I am Professor Asif Qureshi. Today we are going to talk about chapter number 3 from 10 teachers gynae, and the chapter is basically the hormonal control of menstrual cycle and some hormonal disorders. So primarily we will try to understand, because these are still the initial chapters. Chapter number 3 है, हमने पहले chapter में we talked about the normal anatomy and development. Second chapter में we talked about history, examination, investigations, and now we want to discuss what is normal physiology of menstrual cycle, paying an attention towards gynecology aspect. Okay, very important. Menstrual cycle के phases, इसके concepts, they are big time important because ये आपका एक basic conceptual core बनाते हैं and exam में ये बहुत ज़्यादा पूछे भी जाते हैं, right? So the learning objectives of the chapter include to describe features of the normal menstrual cycle. इस पे ज़्यादातर हमारा discussion रहेगा कि what are the different phases and what are the appropriate hormonal control for different stages of menstrual cycle. और उस menstrual cycle के दौरान what are the changes which are happening in the ovary and what are the concomitant changes which are also happening in the endometrium. Because जब ये cycle पूरा अभी हम discuss करेंगे तो how it basically works is कि ओवरी और यूट्रस में दोनों तरफ चेंजेस हो रही होती हैं थ्रू आउट द मेंस्ट्रुअल साइकिल. सो व्हाट्स हैपनिंग इन द ओवरी इज द टॉपिक ऑफ डिस्कशन एंड व्हाट्स हैपनिंग इन द यूट्रस इज आल्सो द टॉपिक ऑफ डिस्कशन. ओके, then describe the normal changes which occur during puberty and at the age of adolescence, puberty, and secondary sexual characteristic differentiation. Then we also will try to understand and classify causes of abnormal puberty and disorders of sexual development, DSDs. We will also spend some time on describing the causes and investigation of primary and secondary amenorrhea, which means कि menstrual cycle missing है. Primary amenorrhea, that menstrual cycle never appeared. So the female has reached to an age of menarche, but the menstrual cycles have yet not begun. So that is primary amenorrhea. And secondary amenorrhea basically means that there were initial months with menstrual cycle, but now there is no menstrual cycle. So that's secondary. It can be because of pregnancy or because of some disease. And then oligomenorrhea also. This also primarily deals with lack of menstrual periods in terms of not absolute absence, but ये है कि bleeding कम हो जाएगी, right? Oligomenorrhea. Heavy menstrual bleed इस चैप्टर का टॉपिक नहीं है. दिस इज कंसिडर्ड एज अ सेपरेट एंटिटी. हम इसको अलग एक चैप्टर में डिस्कस करेंगे. उस पर पूरा एक चैप्टर है 10 टीचर्स में. Now understand the epidemiology and effects of polycystic ovarian syndrome. This is also an important topic, very common these days. इसकी diagnosis कैसे करनी है, manage कैसे करना है, and also to describe the common effects and management of premenstrual syndrome. So menstrual days से पहले what type of syndrome females experience. Some of the females, not all of them. Describe also the premature cessation of periods. यानी अगर एक मेनोपॉज की एज है उससे बहुत पहले अगर किसी वजह से पीरियड्स बंद हो जाते हैं, so this is called premature cessation of periods. So why is this happening? Okay, so this chapter will consider hormonal control, normal hormonal control of the menstrual cycle, and also we'll talk about the abnormalities which are associated with the initiation, regulation, and cessation of the cycle. और सबसे पहली चीज जो हमें कंसिडर करनी है, that is the physiology of the menstrual cycle. So first we'll understand the physiology, then we'll understand what happens if something goes wrong. लेकिन ये फिजियोलॉजी बहुत इंपॉर्टेंट है बिकॉज इसके तमाम फेजेस और हर फेज में कौन सा हार्मोन रिलीज हो रहा है, how the ovaries are under the instruction from pituitary, and how the ovaries then control what happens in the uterus. This is all part of the menstrual cycle and you need to understand that, right? So external manifestation of a normal menstrual cycle is the presence of regular vaginal bleeding. So if you ask a layman, if you ask somebody who does not know physiology or medicine, उनसे आप पूछेंगे what is menstrual cycle, so what they see is what they explain is the menstrual cycle. They see menstrual cycle as vaginal bleeding, and this is what to them is menstrual cycle. However, this bleeding is the last step, is the last phase of the menstrual cycle, and this occurs as a result of shedding of the endometrial lining. So uterus की जो internal endometrial lining है उसकी shedding is observed as bleeding, but that's the very last step. इससे पहले और बहुत सारे steps होते हैं, right? So let's talk about those steps in a minute. The cycle depends on changes occurring after the puberty within the ovaries and fluctuation of ovarian hormone levels, which are themselves controlled by the pituitary and hypothalamus. So the hypothalamic-pituitary axis जो है, ovarian axis, ये टर्म आपको याद रखना है, HPO. मैंने अभी थोड़ी देर पहले भी ये बात आपको बताई कि what happens basically is that at the top you have the master controllers, the hypothalamus and the pituitary. They send their signals to ovary, and then in turn ovary secretes particular hormones and send the signals to the uterus. So combined this is known as hypothalamo-pituitary-ovarian axis. इसमें U भी add करना चाहिए for uterus, but basically uterus is undergoing all the changes which are under the direct control of ovary. So HPO is the word that we very routinely use for this axis. Okay, तो ये भी हमको समझना है. So let us start our discussion by the role of hypothalamus. It is obviously present in the forebrain, you know that. It secretes the peptide hormone which is known as GnRH. Super important terminology, gonadotropin releasing hormone, and this in turn controls the pituitary hormone secretion. So hypothalamus at the very top, then the pituitary, and the GnRH must be released in a pulsatile fashion, release stop fashion, to stimulate the pituitary secretion of what? Of luteinizing hormone. So hypothalamus से क्या निकल रहा है? GnRH, और वो क्या रिलीज करवा रहा है? वो luteinizing hormone and follicle stimulating hormone. अब ये दोनों hormones कहाँ जाएंगे? ये obviously जाके ovary पे act करेंगे. So the pituitary gland, hypothalamus important, क्या रिलीज हो रहा है? GnRH. This is very very important for you to understand. पिट्यूटरी से क्या रिलीज हो रहा है? पिट्यूटरी से दो चीजें रिलीज हो रही है, एक FSH और दूसरे का नाम है luteinizing hormone. So GnRH stimulation of the basophil cells in particular in the anterior pituitary gland, तो ये सब details important है, causes synthesis and release of FSH and LH. This process is modulated by ovarian sex steroid, estrogen and progesterone. Low levels of estrogen have inhibitory effects on LH production. Super important line. So if levels of estrogens are low, then there is an inhibitory effect on LH production, okay? Negative feedback. Whereas high levels of estrogen will increase the LH. So it is going in the same direction. Low estrogen, low LH. ये बहुत इंपॉर्टेंट है यार, पूरी गायनाकोलॉजी के बेसिक प्रिंसिपल्स इस पे आगे चल के फिक्स होने हैं, तो ये बात आपने याद रखनी है. लो ईस्ट्रोजन लीड्स टू लो ल्यूटेनाइजिंग हार्मोन प्रोडक्शन. मोर ईस्ट्रोजन लीड्स टू मोर ल्यूटेनाइजिंग हार्मोन प्रोडक्शन. Okay, simple as that. So negative in the negative direction, positive in the positive direction. The एक्चुअली यहाँ पे बहुत सारे लोग आर्ग्यू भी करते हैं, बट दैट इज हाउ यू एक्सप्लेन थिंग्स. आपको बेसिक कोर पता होना चाहिए. मैनी पीपल आर्ग्यू कि अगर एक चीज बढ़ रही है और दूसरी चीज कम हो रही है, दिस इज व्हाट वी एक्चुअली ट्रूली कॉल द नेगेटिव फीडबैक इन टर्म्स ऑफ फिजियोलॉजी, राइट? दैट्स द बुक, they have chosen this. So anyways, but आपको ये कॉन्सेप्ट पता होना चाहिए कि high level estrogen increase LH production. Okay, the mechanism of action for the positive feedback effect of the estrogen involves, and बल्कि मुझे ये अटका हुआ है दिमाग में, to me this should have been a positive feedback instead of negative, right? Because from our understanding in physiology many students will be confused here, right? इसलिए मैं इसको थोड़ा सा बार बार एक्सप्लेन कर रहा हूँ कि estrogen और luteinizing hormone go in the same direction, so perhaps the positive feedback terminology. Okay, so the mechanism of action for positive feedback effect of estrogen involves an increase in the GnRH receptor concentration, while the mechanism of the negative feedback effects is uncertain. तो जिसको ये negative कह रहे हैं वो ये है कि how the low levels of LH are associated with low levels of estrogen. The high levels of circulating estrogen in the late follicular phase of the ovary act like a positive feedback mechanism to generate a peri-ovulatory LH surge from the pituitary. So अब यहाँ क्या बात हो रही है? यहाँ पे देखें basic principle आपने set करना है. If there is more estrogen, there is more luteinizing hormone. But that's the rule of thumb. And ये important भी है क्योंकि this is then required for ovulation, and this is exactly what happens just around the ovulation time. अभी हम आगे बात करेंगे. But इस पूरे पैराग्राफ से अगर if you have to take something out, तो वो ये है. पिट्यूटरी ग्लैंड से कौन से हार्मोन्स रिलीज होते हैं? FSH एंड LH. LH का मैंने आपको डायरेक्ट रिलेशन बताया है विद द लेवल्स ऑफ ईस्ट्रोजन. और estrogen basically कहाँ से आ रहा है? That's from the ovary. Okay, the clinical relevance of these mechanisms is seen in the use of combined oral contraceptive pills, which artificially creates a constant serum estrogen level in the negative feedback range, indicating a correspondingly low levels of gonadotropin hormone release. So low levels of GnRH if you are taking contraceptives. Now, unlike estrogen, low levels of progesterone have a positive feedback effect on pituitary LH as well as FSH secretion. And it contributes to the LH and FSH surge. So estrogen particularly with LH and progesterone with both of them. Okay, and high levels of progesterone as seen during the luteal phase, ये भी हम थोड़ी देर में बात करेंगे. It inhibits LH and FSH production. तो ये अब आपको ना इसी तरह से आपको ये याद रखना है। और रीजन ये है कि यार ये जो अभी पैराग्राफ्स हमने डिस्कस किए ना, they are the core of your understanding for the rest of gynecology lectures. Please, please, please pay attention. Estrogen के लिए rule of thumb मैंने आपको बता दिया. If there is, मैं बार बार repeat कर रहा हूँ, if there is low estrogen, there is low luteinizing hormone. If there is more estrogen, there is more luteinizing hormone. हो गई बात. अब प्रोजेस्ट्रॉन की कहानी थोड़ी सी डिफरेंट है. अगर हाई लेवल प्रोजेस्ट्रॉन का है तो इट इनहिबिट्स द LH and FSH प्रोडक्शन, ठीक है. और अगर लो लेवल है, if there are low levels of progesterone, then it have a positive feedback, so the secretions goes higher, it contribute to the LH and FSH surge. तो ऐसा नहीं है जैसे ईस्ट्रोजन का था, यहाँ पे थोड़ा सा उल्टा है मामला, ठीक है. ऑलराइट, तो ये टर्म्स जो है ना यहाँ पे थोड़ा सा नॉर्म्स से हटके हो रही हैं, बट जो मैं बार बार एम्फसाइज कर रहा हूँ ना उसको याद रखो. इन टर्म्स को थोड़ी देर के लिए अभी भूल जाओ. सिर्फ ये याद रखो कि ईस्ट्रोजन लो होता है तो ल्यूटिनाइजिंग हार्मोन लो होता है. ईस्ट्रोजन हाई होता है तो ल्यूटिनाइजिंग हार्मोन भी हाई होता है, जबकि प्रोजेस्ट्रॉन में ऐसा नहीं है. प्रोजेस्ट्रॉन इज हाई, it inhibits luteinizing hormone as well as FSH, and if progesterone is low then these are up. Okay, inverse. Now let's talk about the ovary. Starting in the menarche, which is the start of menstrual cycle, the primordial follicles which the females are born with contains the oocyte. They are arrested at the first prophase step in the meiotic division, never completes unless there is fertilization, will start to activate and glow in a cyclical fashion, causing ovulation and subsequent menstruation if there is an event of no fertilization. If there is fertilization, तो फिर zygote implantation अलग कहानी शुरू हो जाएगी. In the course of normal menstrual cycle, the ovary will go through 3 phases. ये ovary के अब हम changes की बात कर रहे हैं. पहला फेज है फॉलिकुलर फेज, दूसरा ओव्यूलेटरी फेज और तीसरा है ल्यूटियल फेज. ये तीनों आपने समझने हैं. आइए इस पे बात करते हैं. द फर्स्ट फेज ऑफ द ओवेरियन साइकिल, अभी हम यूट्रस में नहीं गए, वी आर टॉकिंग अबाउट ओवरी. दैट्स द फर्स्ट फेज, follicular phase, is the initial stage of follicular development are independent of hormone stimulation because this happens even without menarche. तो हार्मोन पे इनका कोई डिपेंडेंसी नहीं है. However, the follicle development will wait at the pre-antral stage, and follicular atresia will ensure if pituitary hormones are absent. So LH and FSH, which are released from the anterior pituitary, they are both very important for final maturation of the follicle. Okay, FSH levels rise in the first days of the menstrual cycle when estrogen, progesterone and inhibin levels are a little low. अब ये सारा combination है. So progesterone का level बहुत low होता है, keeps increasing the FSH levels, right? ये कोई सिंगल इफेक्ट नहीं है, यानी सिर्फ अगर ईस्ट्रोजन है तो ये तो ल्यूटिनाइजिंग हार्मोन पे इफेक्ट कर रहा होता है. हियर वी हैव आल्सो प्रोजेस्टेरोन गोइंग लो एंड FSH गोइंग हाई. ओके, दिस स्टिमुलेट्स अ कोहॉर्ट ऑफ स्मॉल फॉलिकल्स ऑन द ओवरीज टू ग्रो. कुछ अब ये नाम से जाहिर है ना, फॉलिकल स्टिमुलेटिंग हार्मोन है. सो ओवरी में FSH ने जाके क्या काम करना है, स्टिमुलेट करना है फॉलिकल्स को. सो इट एक्चुअली स्टिमुलेट्स अ फ्यू फॉलिकल, ऐसा नहीं किसी एक को जाके पिक करता है. सम ऑफ देम स्टार्ट्स ग्रोइंग एंड विद इन द फॉलिकल्स देयर आर 2 सेल टाइप्स दैट आर इन्वॉल्व्ड इन द प्रोसेसिंग ऑफ स्टेरॉइड इंक्लूडिंग ईस्ट्रोजन एंड प्रोजेस्टेरोन. दीज आर द थीका सेल एंड द ग्रैन्युलोसा सेल. दिस इज द कंपोजिशन ऑफ द फॉलिकल, 2 टाइप्स ऑफ सेल्स, थीका एंड ग्रैन्युलोसा, एंड दे आर बोथ रिस्पॉन्सिव टू LH and FSH stimulation respectively. Okay, the LH यानी ल्यूटिनाइजिंग हार्मोन ये कहां से आ रहा है? It's coming from the pituitary. It stimulates the production of what? Androgen from cholesterol within the theca cell. Super important line, ladies and gentlemen. LH produces androgen in the ovary, in the follicle, converted from cholesterol. Which cells do that? Theca under the influence of LH. Bang on, important line. These androgens are converted into estrogen by the process of aromatization in the granulosa cell. Now the granulosa cell. So theca cells, then granulosa cell. And this happens under the production of FSH. So, अगर मैं आपसे ये पूछूं कि estrogen का production, so imagine this now. This is the ovary, right? And ये ovary के अंदर एक follicle है जो अब mature हो रहा है. It is ultimately producing estrogen. Now this estrogen is controlled in a 2-step fashion. पहले step में ल्यूटिनाइजिंग हार्मोन आएगा, दूसरे स्टेप में FSH आएगा. नाउ व्हाट दे डू, ल्यूटिनाइजिंग हार्मोन ने क्या करना है, थीका सेल्स में इट विल लीड टू द प्रोडक्शन ऑफ एंड्रोजेंस एंड देन द एंड्रोजेंस आर कन्वर्टेड इनटू ईस्ट्रोजन बाय द इफेक्ट ऑफ FSH इन द ग्रैन्युलोसा सेल. भाई मैं ना इसको येलो या रेड या कोई और कलर से भी हाईलाइट करता हूं बिकॉज दीज आर सुपर इंपॉर्टेंट लाइंस. वीडियो को रिपीट कर करके ना इस 1 मिनट को बार बार सुनो. दिस इज वेरी इंपॉर्टेंट. ओके, now if we talk about the follicles growth further, estrogen secretion increases. Estrogen बनना शुरू हो गया ना follicle के अंदर under the effect of LH and FSH. Now estrogen की secretion बढ़ेगी, and there is a negative feedback on the pituitary for FSH, so it goes down, and this assists in the selection of one follicle to continue its development. वरना अगर ये रिलीज होता रहता है FSH, तो एक फॉलिकल, दूसरा फॉलिकल, तीसरा फॉलिकल सब ग्रो हो रहे होते हैं. तो नेचर ने अपना एक सिस्टम रखा है, दिस इज द सिलेक्टिव मॉडल, जिसमें जब एक फॉलिकल ग्रो कर जाता है वो इतना एस्ट्रोजन रिलीज करता है कि FSH इनहिबिट हो जाता है. ओके, in the ovary follicles that has the most efficient aromatase activity because it is required for formation of estrogen and highest concentration of FSH induced receptors will be most likely to survive as FSH levels drop, while smaller follicles will undergo atresia. So जो 2-4 follicle बड़े होना शुरू होते हैं, they will all undergo atresia. The one which is the fittest will survive. और fittest की यहाँ पे definition क्या है? It has highest amount of aromatase and also the LH receptors, FSH induced obviously. There are other autocrine and paracrine mediators playing role in the follicular phase of the menstrual cycle. This include inhibin and activin. इनके बारे में कम बात होती है, but they are also very important players. Inhibin is secreted by the granulosa cells. And मैंने आपको बताया ना कि follicle जो grow करता है, इसमें 2 cells हैं, theca cell और granulosa cell. So inhibin is from the granulosa cells within the ovaries. It participates in feedback to the downregulate FSH release, to downregulate the FSH release. And तो एक दफा जब फॉलिकल ग्रो कर गया ना, अब FSH को शट अप करना है, इसको शट डाउन करना है. वो एस्ट्रोजन भी कर रहा है, वो इनहिबिन भी कर रहा है, इसका तो नाम ही इनहिबिन है. एक्टिविन इज स्ट्रक्चरली सिमिलर टू इनहिबिन बट हैज एन अपोजिट एक्शन. इट प्रोड्यूसेस inside, it is produced inside the granulosa cell and in the pituitary also, and it acts to increase the FSH binding to the follicle. So ये सारे आपको नाम और इनके काम important है. IGF-1 and 2 insulin-like growth factors, they are also important regulators. Circulating levels do not change during the menstrual cycle, but follicular fluid levels increase towards the ovulation, with the highest level found in the dominant follicle. Not too important for you to remember, but if you have to remember something, that will be FSH, LH, and production of estrogen, and perhaps activin and inhibin. Okay. Kiseptins are also important protein molecules. They have been found to play a role in regulation of the hypothalamic-pituitary-ovarian axis because they mediate metabolic hormone leptin's effect on hypothalamus. But this is also not routinely asked in the examination. So follicular phase की summary क्या है? Follicular phase की summary ये है कि inside the ovary, a few of the follicles starts growing under the effect of follicle stimulating hormone. As a result, the follicles produce estrogen, and this estrogen then inhibits the FSH production, and then one of the fittest follicle grows. और जब ये grow कर जाएगा तो इसके अंदर ovum पक के तैयार है. Now the next phase is ovulation. हम ovary की बात कर रहे हैं. By the end of the follicular phase, which lasts about 14 days, usually day 14 of the menstrual cycle is where ovulation happens. The dominant follicle, yani the fittest follicle, has grown to approximately 20 millimeter in diameter, so a very big one, visible perhaps on microscopy. As the follicle matures, the FSH induces LH receptors on the granulosa cell to compensate for लोअर FSH. यानी FSH कह रहा है भाई मैं तो जा रहा हूँ, तेरे LH तेरे रिसेप्टर बढ़ा के जा रहा हूँ, तो दे दब LH, और बहुत सारा LH सर्ज होता है. एंड एज अ रिजल्ट ऑफ दिस LH सर्ज व्हाट हैपेंस कि वन ऑफ दी जो मैच्योर और डोमिनेटिव फॉलिकल था उसमें जो ओवम है इट पॉप्स आउट. सो दिस इज द प्रोसेस व्हिच इज नोन एज ovulation. Happens around 14th day. The window is 14 to 16th day, and this is because of the luteinizing hormone and drop in the levels of FSH. लेकिन FSH जाते जाते LH के लिए रिसेप्टर बढ़ा के जाता है. So that's the, हम तो डूब रहे हैं सनम, तुमको नहीं डूबने देंगे. The LH surge is one of the best predictor of ovulation, and this is the hormone detected in urine by most over-the-counter ovulation predictor tests. ये बड़े कॉमन है. अच्छा, क्यों ये इंपॉर्टेंट है ओव्यूलेशन प्रिडिक्ट करना? बिकॉज दोज कपल्स हु आर प्लानिंग टू कंसीव एंड हैव अ बेबी, दे वांट टू नो कि ओव्यूलेशन हुई है कि नहीं हुई है. राइट, दिस इज वेरी इंपॉर्टेंट बिकॉज अगर ओव्यूलेशन टेस्ट पॉजिटिव आता है, सो दिस इज द टाइम उनके पास अब +1 डे टू +2 डे, ये टाइम पे 1 से 2 दिन का टाइम है यार. इसमें अगर स्पर्म्स एंटर होते हैं, दे विल बी फॉर्मेशन ऑफ जाइगोट. चांसेस यही हैं. अगर ओव्यूलेशन के फॉर एग्जाम्पल 5 डेज के बाद स्पर्म्स एंटर होते हैं, द चांसेस गो डाउन ड्रामेटिकली. सो इट इज इंपॉर्टेंट to know कि ovulation कब हुई है. So there are now over the counter predictor test available, strip test है, तो उसमें पता चल जाता है. Otherwise कुछ symptoms भी होते हैं. So there are some body symptoms such as क्योंकि prostaglandin release होते हैं ना, तो इसकी वजह से there is a fever spike. Sometimes there is like changes in the mood, there is pain, the female feels pain. So these are all the indicators, and they also count their days. So day 1 of the menstrual bleed is usually day 1 of the new menstrual cycle. So they count from the first day, and when it is day 14, they predict ovulation. Okay. So ovulation phase की summary क्या है? Ovum निकलेगा. It's available for fertilization, happens around day 14. And then is the next phase luteal. अब ये ovary में जो follicle था, इसमें से ovum तो चला गया, पीछे ये जो बचा कुचा स्ट्रक्चर है, इस बचे कुचे स्ट्रक्चर में मैंने आपको बताया 2 तरह के सेल होंगे. एक सेल टाइप होगी जिसको कहेंगे थीका सेल, दूसरी होगी ग्रेन्युलोसा सेल. तो ये जो पीछे बचा हुआ हिस्सा है, दिस इज देन, ये येलोइश होता है, इसमें ब्लड होता है, फिर हेमरेज होता है, फिर येलोइश टर्न. इस पूरे को एक नाम देते हैं, एंड दिस इज नोन एज कॉर्पस ल्यूटियम. दिस इज वेरी इंपॉर्टेंट नेम फॉर यू टू रिमेंबर, द कॉर्पस ल्यूटियम, बिकॉज दिस कॉर्पस ल्यूटियम देन सीक्रेट समथिंग इंपॉर्टेंट. अभी बताता हूँ थोड़ी देर में. The granulosa cell is corpus luteum. They have a vacuolated appearance and they have a yellow pigment. The corpus luteum undergoes extensive vascularization in order to supply granulosa cell with the blood, because they have to produce something very important. और वो क्या है भी आपको बताता हूँ. Ongoing pituitary LH निकल रहा है इस दौरान, and granulosa cell activity ensures a supply of progesterone, because this progesterone released from this corpus luteum goes and prepares the uterus. Okay, hey, I have now just ovulated. The ovum is just out. It's coming to you. Get prepared. Now, what does preparation means? Preparation means increased blood supply, increased glycogen supply and storage. So who prepares the uterus? Progesterone. From where the progesterone comes? From the corpus luteum. Okay, so it kind of prepares in case if pregnancy happens, right? That's the job of progesterone and corpus luteum. Now, progesterone levels are high at their highest during the luteal phase, and they kind of prepare the uterus. The luteal phase lasts about 14 days. So day 14 पे ovulation हुई, next 14 days is luteal days. So we are reaching up till the time of 28 days. And this is where now the uterus and the body decides that if there is no fertilization, everything shuts down, progesterone levels go down, corpus luteum starts degrading, and uterus की जो भी preparation थी, it sheds it out as blood, which is the last phase of the menstrual cycle. Okay, so that's how it is. Simple. And the new cycle begins. So day 1 of the bleed is day 1 of the new menstrual cycle. Ovary में 3 phases याद रखने हैं बॉस आपने. देखें, it's very important, right? The first phase is the follicular phase, जिसमें follicles mature होंगे. The second phase is the ovulation. And the third phase is basically the luteal phase. हर एक का regulatory hormone आपको पता होना चाहिए. यहाँ FSH and LH, और फिर उनसे क्या बन रहा है, estrogen कैसे बनता है, all the story that we just discussed. Ovulation is because of LH surge, and after ovulation, there is heavy production of progesterone, because this then prepares the uterus. Okay? Right. So ovary में ये सब changes हुए. Now we also need to talk about कि मैंने आपसे कहा था कि menstrual cycle में there are changes in the ovary, and then there are also changes in the uterus. So now let us talk about changes in the uterus. और उस changes in the uterus को basically यहाँ पे कहा है the endometrium में changes, because actually uterus का endometrium जो है वही shed करता है during menses, ना? तो let's talk about what happens, what are the changes in the endometrium. Now, the hormone changes affected by the HPO axis during the menstrual cycle will occur whether the uterus is present or not. However, specific secondary changes in the uterine endometrium give the most obvious external sign. External sign क्या है menstrual cycle का? The bleeding. And this is dependent on the uterus, right? Although अगर आप uterus निकाल भी दें, even if you do the hysterectomy for some reason, the cycles will continue, क्योंकि ovary अगर मौजूद है और hypothalamus मौजूद है और pituitary मौजूद है, this will continue. The only bit कि यहाँ से जो signals uterus को जा रहे हैं और जो uterus से every month bleed हो रहा है वो नहीं होगा अगर uterus नहीं है. Okay? Now, what are the phases of this secondary change in the menstrual cycle जो uterus में होते हैं? The first one is the proliferative phase. There is a secretory phase, and then there is another phase which is the last one, which is what we call the menstruation, which is the final phase जिसमें bleeding होती है, right? So let's see what are the changes in the uterus in the first phase, which is proliferative. The endometrium enters the proliferative phase after the menstruation, where glandular and stromal growth begins. So basically endometrium में increased gland, increased vascular supply, increased growth, all this happens. And this is obviously under the effect of hormones in the body, but that's a regenerative and repair phenomena. क्योंकि अभी पिछले cycles आप देखें ना, there is bleeding, so bleeding के बाद it has to be repaired. The epithelial lining of the endometrial gland changes from a single columnar to pseudostratified. Endometrial thickness rapidly increases, और particularly secretory phase में तो फिर आप देखें कि जब ovulation हो जाती है तो corpus luteum बन गया है, उसमें से फिर progesterone release हो रहा है, right? So वो जो progesterone release हुआ है वो तो फिर further prepare करता है uterus को. So progesterone induces the formation of a temporary layer which is called decidua, which has increased blood supply. So uterus go the real thickening changes and blood supply changes because of progesterone. During which phase of the ovarian cycle? During the luteal phase, right? तो अब आपको ये दोनों मिक्स एंड मैच करना है कि जब ओवरी में फॉलिकुलर फेज चल रहा होता है तो यूट्रस में क्या चल रहा होता है, जब ओवरी में ओव्यूलेशन होती है तो यूट्रस किस स्टेज पे है, जब ओवरी में ल्यूटियल फेज चल रहा है तो यहाँ पे क्या चल रहा है, यहाँ सिक्रेटरी फेज चल रहा है, राइट? इट्स बिकमिंग प्रिपेयर्ड फॉर द if next pregnancy happens or the first pregnancy happens, right? Your diagram is a good diagram telling you what is happening in the ovary and then what is happening in the endometrium. So abhi main ye diagram zarur explain karunga, lekin before that let's go through this paragraph of menstruation. So menstruation, day one is the shedding of the dead. So theoretically this is what happens, right? This is ovary, right? And these are in fundibulum, dono side pe honge, and then there is uterus. So hypothalamus, then pituitary, all the hormonal things, ovum release hua, ovum fertilized nahi hua, right? तो डे 1 से डे 14 दिस इज द फॉलिकुलर फेज जिसमें फॉलिकुलर ग्रोथ हो रही है. डे 14 पे ओव्यूलेशन हो गई, दिस इज डे 14, और डे 14 से डे 28 तक दिस इज गोइंग थ्रू लाइक दिस, राइट? लेकिन ये जो पूरा डे 14 से डे 28 है विच इज द ल्यूटल फेज इन द ओवरी, बट यू नो प्रिपरेटरी फेज, सिक्रेटरी फेज हेयर इन द यूट्रस. तो यहाँ पे डेसिडुआ, इंक्रीज ब्लड सप्लाई, इंक्रीज ग्लाइकोजन, एंड देन 14 days passed and no fertilization. Now this hormonal support cuts off and the endometrial lining sheds off, right? This is the bleeding phase, and this is happening at day 28 when the progesterone support is gone and it is now almost confirmed that fertilization has not happened. तो ये जो bleeding है, this is called menstruation. And day 1 पे this is what happens, the dead, it becomes dead, the endometrial lining, and everything comes out. It continues for about 4 to 5 days, in some females more, in some females less. And immediately prior to menstruation, 3 distinct layers of endometrium can actually be seen. This is not so important. A fall in the circulating levels of estrogen and progesterone 14 days after ovulation leads to the loss of tissue. ये जो मैंने बात यहाँ की थी कि ये मतलब इन अ वे अगर इसको जनरल वे में देखें तो 14th डे पे ओवम आया था ना. Now it is waiting for another 14 days कि if fertilization happen. If not, the support from progesterone, estrogen is gone and this becomes dead. The effect of estrogen and progesterone on the endometrium can be reproduced artificially. For example, in the patients taking combined oral contraceptive pill, HRT, hormone replacement therapy, who experience a withdrawal bleed. So, ये जो effects हैं estrogen, progesterone के, ये हम use करेंगे अगले chapters में to understand the concepts of hormonal replacement therapy or contraceptions. Now, the vaginal bleeding will cease 5 to 10 days on average as arterioles vasoconstrict, and then this is over. But remember, day 1 of the bleed is day 1 of the next menstrual cycle. Okay, that is how you count the days. The endocrine influences in menstruation are very clear. However, the paracrine mediators are less so. So prostaglandin, F2 alpha, endothelin 1, platelet activating factor, and vasoconstrictors are also produced within the endometrium during the phases of menstruation. So the uterus is basically going through a lot of chemical environment, right? Including prostaglandins, endothelins, PAF, and this is the reason some females have pain, because you are producing prostaglandins, and perhaps NSAIDs is the treatment for controlling this painful period. Endometrial repair involves both glandular and stromal regeneration. You require VEGF for and also other mediators such as insulin-like growth factors, transforming growth factor. So alongside menstruation, a lot of repair mechanism, wear and tear, normal wear and tear is also going on within the uterus. So अब हम आते हैं इस diagram पे, because without this diagram, this is not complete, और ये समझ में नहीं आने वाली बात, right? So this is the end point. This is the end point. We're looking here as menstruation. This is what you see as the blood. So bleeding, this is the menstruation. But what's happening before that? क्योंकि देखिए menstruation का जो day 1 होगा, so that is actually day 28 of the previous cycle. ऐसे ही है ना? 28 दिन से वो साइकिल चल रहा है, तब जाके इस पॉइंट पे कुछ भी नहीं हुआ, then menstruation begins, right? तो पीछे 28 दिन की स्टोरी आपको पता होनी चाहिए कि शुरू के डेज में डे 1 to डे 13 या 14 तक क्या चल रहा होता है, दिस इज नोन एज द फॉलिकुलर फेज. ओवरी में क्या चेंजेस होते हैं, फॉलिकल ग्रो करता है. और एंडोमेट्रियम में क्या चेंजेस होते हैं, एंडोमेट्रियम शुरू के दिनों में तो it is going through bleeding, but then it has a repair phenomena. So early 14 days uterus is repairing, and early 14 days ovary में ovum is developing. Day 14 पर क्या होगा, ovulation. Ovulation के बाद until day 48 what is happening, ओवरी के अंदर पीछे जो बच गया वो कॉर्पस ल्यूटियम है, एंड व्हाट इट इज प्रोड्यूसिंग, प्रोजेस्टेरॉन. और इन 14 डेज में, ओव्यूलेशन के बाद के 14 डेज में यूट्रस में क्या हो रहा है, इट इज प्रिपेयरिंग फॉर प्रेगनेंसी. इफ प्रेगनेंसी डज नॉट हैपन, इट ब्लीड्स. ओके, सिंपल एज दैट. इफ प्रेगनेंसी हैपेंस, देन दिस फेज विल नेवर हैपन. There will be no menstruation, and we'll talk about it when we do pregnancy lectures. So here, if you look at the diagram, this is you should be able to differentiate. This is definitely something where there is hypertrophy, more glands, so the uterus is now preparing well for pregnancy. That is the secretory phase of the uterus. Okay, so अब हमने तो ये menstrual cycle का normal physiology थी, normal hormonal control that we talked about, and now we have to jump on to another very important concept in this chapter, which is about puberty and development of the secondary sexual characteristics. So let us now first talk about normal puberty, and then we'll take the discussion from there. So puberty is the process of reproductive and sexual development and maturation that changes a child into an adult. So this is a series of events, obviously based on hormonal changes, and that leads to changes in the morphology and structure of a person. So the child ultimately develops into an adult. So that is what we call puberty. And during the childhood, the hypothalamic-pituitary and ovary axis is suppressed, and levels of GnRH, FSH, and LH, they are all very low, and this is during the childhood. However, from the age of 8 to 9 years, GnRH is secreted in pulsations of increasing amplitude and frequency, and these are initially sleep related, but puberty progress जैसे जैसे होती है, these extend throughout the day. Pulsatile release of GnRH from hypothalamus. So होता ये है कि this stimulates the release of FSH and LH from the pituitary, and they go and work on to the ovary. So they trigger, basically the follicle stimulating hormone triggers the follicular growth in the ovary. And also steroids are produced. The estrogen, which is produced by the ovary, then initiates the physical changes. So ultimately ovary में जो developing follicles हैं, so the story basically is that the GnRH from the hypothalamus goes to pituitary, and pituitary releases FSH and LH, and as a result of these, the follicles grow in the ovary. Estrogen is produced, and this is the one chemical which initiates physical changes of the puberty. The exact mechanism determining the onset of puberty is still unknown. This is a very important point. Actually, many of the things in medicine and physiology we have explained, but there are still many things which we actually don't know. But it is influenced by many factors such as race, heredity, body weight, exercise, insulin resistance, a lot of different dietary patterns. There's so many things which leads to either early puberty, late puberty, things like that. Physical changes occurring during the puberty are multiple. So for example, there is breast development, and the medical terminology for that is thelarchy. There is appearance of pubic and axillary hairs, and the word for that is adrenarche. And obviously there is a growth spurt, so height increase hoti hai females ki, and there is onset of menstruation, which is called as menarche. So menarche is the word which is known to many people, but you should also, as a medical student, you should know thelarchy, which is breast development, and adrenarche, which is growth of hair in the axillary and pubic region. So all of these, thelarchy, adrenarche, and menarche, they constitute together puberty. The first physical signs of puberty are breast budding, so outpouching of breast bud, and this occurs 2 to 3 years before menarche. So once this starts, this is an indication that down the line, 2 to 3 years after this, the menses will begin. The appearance of pubic hair is dependent on the secretion of adrenal androgens and is usually after thelarchy. In addition to increasing levels of adrenal and gonadal hormones, growth hormone secretion also is increased. That leads to pubertal growth, so increase in height. The mean age of menarche generally is 12.8 years, but that is in a particular context from where the book is published, obviously. So it varies from region to region. However, it may sometimes be delayed, sometimes be early. Okay. Initial cycles are usually anovulatory, which means the bleeding is there, but ovum is not there, and they may be irregular for actually a few years of menarche. The absence of menstruation is known as amenorrhea. So, in a female who has reached the age of menarche or actually bypassed it and no signs and symptoms of any menstrual periods, so that's called primary amenorrhea. And secondary amenorrhea is that the menstrual cycle is started but then stopped. Pubertal development was described by Tanner, and stages of breast and pubic hair development are therefore labeled even today as Tanner 1 to Tanner 5. So these are, and we'll go through the image to see what are the different Tanner stagings. Here you see these are the Tanner staging images in the breast and in the pubic hair area. So Tanner 1 is the first stage. This is actually pre-pubertal. Then you see Tanner 2, breast and papilla are elevated and the areola increases in diameter. You also see sparse pubic hairs, and then there is further enlargement of breast, which is Tanner 3 to Tanner 4, where further growth and darkening of pubic hairs, and then finally Tanner 5, which is mature breast counter and the adult pubic hair pattern. So these are the Tanner staging, nicely depicted on these diagrams. This word precocious puberty, this is defined as the onset of puberty before the age of 8 in a girl or 9 in a boy, because puberty is not obviously going to come only in female, also the boys. Obviously the patterns are different, the hormones are different, so thelarche, adrenarche, and menses, I mean, all of them are not present in boys, obviously. But if the puberty happens before 8 or 9 in females and males, respectively, this is what we call precocious puberty. It is classified as either central or peripheral. So the cause can be in the central axis, which is what we mean by hypothalamus and pituitary. But it can be peripheral cause. So central precocious puberty is gonadotrophin dependent, which means hypothalamus is involved. The etiology is often unknown. However, in 25% are due to central nervous system malformation or even brain tumors. So precocious puberty, brain tumor, important association. So you should, if you are investigating a patient with precocious puberty, this is perhaps something to be considered in the workup. Peripheral precocious puberty, which is gonadotrophin independent, because centrally everything is fine. It is always pathological and can be caused by estrogen secretion, such as from somewhere else, a hormone producing tumor in the periphery. The term delayed puberty, as the name indicate, when there are no signs of secondary sexual characteristics by the age of 14 years, and this is termed as delayed. It can again be because of central issues, which means that the hypothalamus is not working fine, hypogonadism, or a failure of gonadal function, which we will discuss in a minute. So if you look at this important box, this is box 3.1, hypo and hypergonadotrophic hypogonadism. So the gonads are hypogonadism, as the name indicate, in hypo situation. So hypogonadotrophic hypogonadism. Let us discuss what is it and then try to understand the terminology. This is central and maybe constitutional, but other causes must be excluded. These include anorexia nervosa, excessive exercise, chronic illness. They can all contribute to hypogonadism, but हाइपोगोनेडोट्रॉफिक का मतलब यह है कि जीएनआरएच के रिलीज में ही इशू है यानी हाइपोथैलेमस में इशू है, इसकी वजह से हाइपोगोनेडिज्म है. एंड there are some rare causes and some commonly such causes which can be commonly excluded. For example, too much exercise, chronic illness, diabetes, renal failure, anorexia, sometimes some tumors in the pituitary, Coleman syndrome, and this is associated with obviously primary amenorrhea because the central system is not working, hypothalamus is not working, GnRH is not being released, so primary amenorrhea and delayed puberty. Okay. Then hypergonadotrophic hypogonadism, this is caused by gonadal failure, which means the central system is working fine. GnRH is okay, this is releasing okay from hypothalamus, and then the pituitary is fine, so it is also releasing FSH and LH okay. But then the gonads, which means the ovary, this is not responding. So as a result, there is a lot of hypothalamic and pituitary hormones, but the gonads are not working. So hypogonadism, but hypergonadotrophic. So now you understand the term, right? The gonads does not function despite high gonadotrophins. These are associated with Turner syndrome, which is pretty common, and double X gonadal dysgenesis. Premature ovarian failure can occur at any age, including prior to puberty or maybe idiopathic. So ovarian failure, ovaries simply decide not to be productive. Associated and delayed puberty and primary amenorrhea can happen in these patients. Hypergonadotrophic hypogonadism can also occur later in life, which will cause secondary amenorrhea. So primary amenorrhea, it never started. Secondary amenorrhea, there were periods of menstrual cycle, but now it's not working. Okay, so these are some important terminologies associated with puberty and if the gonads are not working. So gonads cannot work either in the situation where the central system is not working. When I say central system, it basically means hypothalamus and pituitary. And then there is a situation where the central system is okay, but the gonads are not working. So this is hypogonadism, but hypergonadotrophic. If the central system itself is defective, this is hypogonadotrophic hypogonadism. So look at the words, try to identify the meaning. With this, we now move on to some disorders associated with sexual development, DSDs, also very important. For example, obviously, by definition, DSDs are conditions where the sequence of events described above does not happen. And the clinical consequence of this depend upon where the sequence, where the variation in the sequence happens. और अभी हम इसके बारे में पढ़ेंगे भी. DSD may be diagnosed at birth, even nowadays before birth, because there are no techniques available. And at birth particularly, there can be ambiguous or abnormal genitalia, which are indicative of DSDs, sexual development disorders, but also be seen at puberty in girls who present with primary amenorrhea. So if there is a female presenting to you with primary amenorrhea, and this is where you start suspecting that there may be sexual development की disorder. यानी जिस एज पर puberty होनी थी वहाँ puberty नहीं होगी, थीलार्की नहीं दिखेगी, एड्रिनार्की नहीं दिखेगी, menses नहीं होंगे, and this is how you come to know कि puberty पर वो सारे signs और puberty के जो characteristic हैं, secondary sexual characteristics, they are all missing. And if menses never happen, which is what we call primary amenorrhea, then you start thinking about developmental disorders, sexual developmental disorders. There are different categories, और उनके बारे में भी हम पढ़ते हैं. There has been change in the terminology used to refer to these conditions over the last 10 years. Old terms such as hermaphrodite, ये पहले use करते थे, intergender, intersex, अब ये terms change होना start हो गई हैं. These are the terms which were previously used. Intersex word use करते थे, male pseudo hermaphrodite, under viralization of XY male, under masculinization of XY male. But now the accepted terminologies are rather chromosomal, which is much more scientific and nomenclature based, right? So 46XY DSD, 46XX DSD, ovotesticular DSD, which means both gonads are present. So these terms have now basically changed, right? And more importantly, exams में और clinics में जो आपने नाम use करने हैं. So for example, Turner syndrome, you should know what it is. The total complement of chromosome is 45 in Turner syndrome. So that is a disease where the count is not 46. So it's a 45 chromosome in Turner syndrome, which results from a complete or partial absence of one X chromosome. So usually, अगर कोई हम फीमेल की बात करते हैं, so the total number of chromosome would be 46, right? और अगर मैं पूछूंगा इन 46 में से gender chromosomes कितने हैं, sex chromosome 2x. This is what a female is. अब इसको हम ऐसे भी लिखते हैं, इसको 44 plus XX भी लिखते हैं, but there are 2x chromosome. If one X chromosome is completely missing, तो total number of chromosome कितने बचे? 46 के बजाय बच गए 45. So 45XO is Turner की जो presentation है जिस तरह लिखा जाता है, that's how you write it. Turner syndrome is the most common chromosomal abnormality in females, occurring in 1 in about 2,500 live female births. So it's a big number, you can imagine, 2,500 में एक. A mosaic karyotype is not uncommon, leading to variable presentation. So some cells have this pattern, 45XO, some of them are normal. So this is what we call the mosaic pattern. Although there can be variation, the most typical clinical feature includes short stature. ये characteristic features हैं, exam में ये अक्सर वो use करते हैं. Webbing of neck is classical and wide carrying angle. So ये तीनों अगर words use हो रहे हैं ना clinical vignette में, think about Turner syndrome, do the karyotype, see if it is 45XO. Associated medical conditions include coarctation of aorta, inflammatory bowel disease, sensorineural and conduction deafness, renal anomalies, and so all these can also be given in the examination. And if they are there and they are talking primary amenorrhea, and then you are thinking about Turner syndrome. In this condition, the ovary does not complete its normal development and only stroma of the ovary is present. In fact, इसको हम कहते हैं streak ovaries. So जो normal Graafian follicle या follicle की development होगी, that does not happen, right? So if it does not happen, no estrogen is produced, no ova are produced, no pregnancy, no menstrual cycle. Diagnosis is usually made at birth or in early childhood by the clinical presentation. ये web neck, wide carrying angle, ये सब चीजें पहले ही pick हो जाती हैं, short stature. However, in about 10% of the women, the diagnosis is missed until they reach to the age of puberty and there is no puberty. So this is how you then pick it up. ओवरीज चूंकि स्ट्रीक ओवरीज है, ऐसे समझेंगे जैसे फाइब्रोज ओवरीज हैं इन पेशेंट्स में. दे डू नॉट प्रोड्यूस ईस्ट्रोजन, सो द नॉर्मल फिजिकल चेंजेस ऑफ प्यूबर्टी कैन नॉट हैपन, एंड दे डू नॉट प्रोड्यूस ओवम, and pregnancy is possible sometimes if they are living a life and they want to be pregnant. So sometimes you do ovum donation and these sort of techniques. Ovary का इनका अपना system तो काम नहीं कर रहा, but then implantation can be done. Psychological input and support is very important in girls with mosaicism. The clinical picture may vary. मैंने बताया ना कि 100% सारे cells homozygous नहीं होते for 45XO genotype. Some of the cells may be normal. So if it's mosaic, depending upon how many cells are abnormal and how many cells are normal, the clinical picture may vary. Okay. Then there is another condition that you must know. This is known as 46XY gonadal dysgenesis. So by the look of it, it looks like a male pattern, right? XY. In this situation, the gonads do not develop into testes despite the presence of XY. XY मौजूद है, तो Y chromosome पर although SRY gene होगी, लेकिन testes develop नहीं होता. In about 15% of the cases, this is due to mutation in the SRY gene. Although SRY gene मौजूद है, but mutated है, इसकी वजह से testes develop नहीं हो रही. Incomplete gonadal dysgenesis, अगर बिल्कुल ही gonad develop नहीं हुए, which is also called Swart syndrome, the gonad remains as a streak, जैसे streak ovaries की भी हमने बात की थी, and they do not produce hormone. In the absence of anti-Mullerian hormone, the Mullerian structures do not regress, and uterus and vagina and fallopian tubes may develop. ये आपको याद है ना, आप अगर मेरे earlier chapters देखेंगे, so actually पहला chapter ये था anatomy development के how does it happen. So you know that SRY gene was the one which was responsible for formation of testicular cells, which then lead to formation of AMH. और AMH की वजह से फिर female structures सारे खत्म होते थे, तो uterus नहीं बनती थी, fallopian tubes नहीं बनती. भाई यहाँ तो ऐसा कुछ है ही नहीं ना. So there is mutation in the SRY gene, therefore those cells in the testes are not produced, testis is not produced, and AMH is not produced, and therefore these patients may develop uterus, vagina, and fallopian tube. The absence of testosterone, because they do not have cells, because they do not have SRY gene normally functioning, that means that the fetus also does not viralize. The baby is phenotypically female, genotypically male है XY, but phenotypically दिखने में appears like a female baby, but genotypically XY. The gonads do not function, and the presentation is usually at the adolescent, because parents, raise the baby understanding that the baby is a female baby, और फिर पता चलता है कि जी menses नहीं है. Then you start doing the investigation, do the karyotype, then you understand that the genotype is actually XY. The dysgeneric gonad has a high malignancy risk. अब ये जो streak gonads हैं, इनमें कैंसर हो सकता है, high risk, and maybe you need to remove them laparoscopically to see what is it, diagnosis and management. Puberty must be induced with estrogen. Pregnancies have been reported with a donor oocyte because uterus तो मौजूद है. Ovary नहीं होगी इन patients में, obviously, because इनका जो genotype है वो XY है. Full disclosure, despite uterus and vagina and all these structures being there, ovaries are not there, right? Mixed gonadal dysgenesis is more complex condition. The karyotype may be 46XX, but XX and XY combination or mosaicism can be present, and this then deals with the varying phenotypic structures. For example, if the testis is functional, the baby will viralize and have ambiguous genitalia. So either the genitalia are 100% looking like a female genitalia, or if the cells are mosaic, it may be a mix of male and female genitalia, confused, right? But if the genotype is XY, there will be testes, but streaked. If the genotype is XX, it may be an ovary, but streaked again, not fully functional. तो ये दोनों टर्म्स आपको अच्छे से पता होने चाहिए. व्हाट इज टर्नर सिंड्रोम, व्हाट इज गोनेडल डिसजेनेसिस. इसमें गोनेड नहीं फॉर्म हो रहा. Then there is a situation which is called 46XY disorder. The most common cause is complete androgen insensitivity, CAIS, occurs in individuals where viralization of the external genitalia does not occur because there is androgen insensitivity. Androgen is perhaps there, but it is, the organs which have to develop are insensitive to androgen. Okay. In the fetus with the complete androgen insensitivity syndrome, testes form normally due to action of SRY gene because ये male है, इनमें SRY gene mutated नहीं है, so testes start developing. At the appropriate time, these testes secrete also anti-Mullerian hormone. Therefore, the relevant female structures are gone, and they do not have a uterus. Okay, this is important. Now, testosterone is also produced क्योंकि testis produce हुआ है ना at the appropriate time. However, due to inability of androgen receptor to respond, the external genitalia do not viralize. तो अब जब ये viralize नहीं होंगे, so it looks like a female external genitalia. So now this scenario is different from what we discussed earlier. Here, testes are present. They are present because SRY gene mutated नहीं है. So since testes are present, testosterone भी बन रहा है. But then the external genitalia, they are insensitive to the androgen. So therefore they do not viralize and they persist as female external genitalia. So male genotype, testis present, uterus, vagina absent, but external genitalia like female. The baby is born with normal female external genitalia. Parents think this is a female baby, but then later on they start seeing कि testes भी है, वो descent हो रही है, things like that. Presentation is usually at puberty when the primary amenorrhea is there because they are suspecting or they are expecting the baby to be a female baby, but it's actually not a female baby, it's a male baby with testes. Only the external genitalia are female, right? And the female baby then says that, well, there is no menses, there are no secondary sexual characteristics being developed. This is where you contact the physician, and then investigations happen, and then you get to know that this is actually a male baby with this particular syndrome, right? And many of the time you also find the testes are stuck somewhere in the inguinal canal because the external genitalia is not that of male, so scrotum develop नहीं होता. In fact, there are labia majoras and minoras. So testis कहाँ जाएगी? Testis बनती तो है. So testis is stuck in the inguinal canal. It does not descend appropriately. You have to remove that because अगर इस testis को inguinal canal में छोड़ दिया, so there are chances of testicular malignancy. Okay, vagina is usually shortened, so this is a surgical treatment of how you can correct it. So these are the surgeries which you perform to take care of the external genitals, right? In case of partial androgen insensitivity, the androgen receptor can respond to some extent. Some viralization happen, but the external genitalia can be ambiguous. Okay. So, I mean, these are very important discussions because देखिए ये सारी चीज़ें ना आपने अपने फिजियो के पैथोलॉजी के लेक्चर्स में पढ़ी हैं, but now we are talking in terms of clinical gynecology scenario. So these patients do present. You need to, imagine these patients coming to your clinic and talking to you. So you should know कि क्या presenting complaints होंगी, उसकी underlying pathology क्या है. 5-alpha reductase deficiency. The fetus is XY karyotype. It's a male karyotype. Testes are normal because SRY gene is there. And testosterone is produced, also AMH. So no female internal genitalia, so uterus, vagina ये नहीं बनता, and testis is present, testosterone is there. However, the fetus is unable to convert the testosterone into dihydrotestosterone. As a result of this, there is no viralization, and female genitalia or externally ambiguous genitalia are present. So looks like a female child, but is actually a male child. Okay, so imagine, I mean, this 5-alpha reductase, there is a problem of androgen conversion. There was complete androgen insensitivity syndrome, जिसमें androgen ठीक ठाक था, but जो organs थे, these were insensitive. So you need to take care of the subtle differences which are present between these pathologies. Then there is a 46XX disorder, जिसमें there is a female XX genotype. Congenital adrenal hyperplasia leads to viralization of female fetus because a lot of androgens are available. It is due to enzyme deficiency in corticosteroid production pathway in the adrenal glands. The problem lies in the adrenal. And in 90% of the cases, it is actually 21-hydroxylase, which actually converts progesterone to decorticosterone, and 17-hydroxyprogesterone to deoxycortisol. So this pathway is disturbed. The reduced level of the cortisol being produced drive the negative feedback loop, resulting in hyperplasia of the adrenal. Adrenal is over and superactive. This leads to an excess androgen precursor and then to elevated testosterone production. So this is what causes excessive virilization. Recall my lectures from pathology and physiology where we talk about congenital adrenal hyperplasia. Raised androgen levels in females will lead to virilization. Female patient looking like a male clitoris is enlarged, sometimes taken as perhaps penis, and the labia are fused. It looks like scrotum. So external genitalia, in this case, this is the first disorder जिसमें you're looking at a female patient and the external genitalia is looking like a male person. Okay. In addition, 2/3 of children with 21 hydroxylase congenital adrenal hyperplasia will also have salt losing variety, which also affect the ability to produce aldosterone because adrenal is involved, right? So aldosterone will be affected. This represents a life-threatening situation, and those children who are salt losing often become dangerously unwell because this is serious. If you lose salt and water balance, it's all disturbed. Once this infant is well and stabilized on their steroid regime, steroid is the treatment because that is the initial problem. Traditionally, all female infants with congenital adrenal hyperplasia underwent feminizing genital surgery within the first year of life because their external genitalia are male looking, so you do the feminizing genital surgery. This management is now controversial as adult patients with CAH are very dissatisfied with the outcome. Obviously, that's if you intervene with nature's stuff, obviously you are not successful 100% of the times and there may be problems, right? At present, cases are managed individually by multidisciplinary teams, so it may require a lot of surgery, a lot of hormonal treatment, a lot of psychological treatment, and also a lot of plastic surgery involvement. So multidisciplinary teams are involved. So ये मैंने 5-6 यहाँ पे disorders आपके सामने रखे हैं. They are super important. You must know all what we discussed about Turner and the rest of the chromosomal disorders. Okay. Then the last bit I think of this chapter is the disorders of menstrual regularity, and terminologies like amenorrhea and oligomenorrhea. You should know amenorrhea is the complete absence. If it is an absence in a way कि कभी भी menstrual cycle start ही नहीं हुआ, this is what we call primary amenorrhea. But if it is there for a time where initially there was menstrual cycle and now there are no menstrual cycle, so this is secondary amenorrhea. It is the absence for more than 6 months and in the absence of pregnancy. So if the person is not expecting to be pregnant and the menses are not there for at least 6 months, you call it amenorrhea. ऐसा नहीं है कि 2 महीने cycles नहीं आए, you say well amenorrhea हो गया. ऐसा नहीं है, right? And oligomenorrhea is defined as irregular period in the intervals of more than 35 days. यानी टाइम पर आने चाहिए थे, उस टाइम पर नहीं आ रहे, उससे ज्यादा टाइम ले रहे हैं. The causes may be at the hypothalamus level, GnRH, pituitary level, FSH, LH, ovarian level, or endometrial level. So, and it can be primary and secondary as we discussed, right? ये पूरा अगर आपको एक्सेस याद है ना, तो आपको ये फिर समझना इतना मुश्किल काम नहीं है. इसमें मैं देख ही रहा हूँ कि कहीं इन्होंने यहाँ डायग्राम ना, but the diagram was right up there. In fact, मैं बना के आपको बता देता हूँ. So remember, there is a hypothalamus, there is pituitary, and then there are ovary, right? So hypothalamus से क्या रिलीज होता है? Growth gonadotropin releasing hormone, which goes and acts on the pituitary, and pituitary क्या रिलीज करता है? FSH and LH, and these go to ovary, and then ovary start developing the follicle, and then also produces estrogen, right? So the problems with amenorrhea can be here at the hypothalamus level, can be here at the pituitary level, tumors or anything, and also can be at this level, at the ovary level. So for example, Turner syndrome, there is a streak ovary, no particular ovum there to develop, ovary का structure ही नहीं है, तो ये सारा एक्सेस ठीक रहता है, ये गड़बड़, तो ये एक्सेस आपको याद होना चाहिए, ठीक है? ओके डॉक्टर, सो बात हम अब आगे बढ़ाते हैं. सम हाइपोथैलेमिक डिसऑर्डर्स जिसकी वजह से एमेनोरिया हो सकता है, एंड दिस विल बी हाइपोगोनेडोट्रोपिक हाइपोगोनेडिज्म की टर्म हमने ऊपर डिस्कस की भी थी. सो इसके कॉमन रीजंस हो सकते हैं वेट लॉस, स्ट्रेस इज अ वेरी कॉमन रीजन फॉर नॉट हैविंग मेंसेस. ओके, एक्सेसिव एक्सरसाइज, एथलीट्स में प्रॉब्लम देखा जाता है कॉमनली. देन देयर कैन बी हाइपोथैलेमिक ट्यूमर सच एज ग्लायोमा, कैरिंजियोफ्रेमा, एंड मे बी अदर शॉक की वजह से ब्लड सप्लाई नहीं है. हेड इंजरीज जिसमें हाइपोथैलेमस डैमेज हो रहा है. कॉलमन सिंड्रोम, इट इज़ रेसेसिव कंडीशन एक्सलाइंग जिसमें GnRH की डेफिशिएंसी है, एंड दैट लीड्स टू आपका साइकिल में अगर अप देयर इन हाइपोथैलेमस गड़बड़ होगी तो पूरा आगे साइकिल चलेगा ही नहीं, देयर विल बी नो मेंसेस. Systemic disorders बहुत सारे हैं which can cause amenorrhea and hypothalamic shutdown. Tuberculosis and sarcoidosis are typical example, and some drugs can do that as well, right? Dopaminic agonists in particular, HRT and progesterones. So ये जो साइकिल मैंने आपको समझाया अभी कहाँ गया, जो डायग्राम बार बार बना रहा हूँ, चलो दोबारा बताता हूँ. हाइपोथैलेमस से क्या निकल रहा है? गोनाडोट्रोपिन रिलीजिंग हार्मोन. तो अभी हम सारे हाइपोथैलेमस के प्रॉब्लम डिस्कस कर रहे थे. नाउ द पिट्यूटरी से क्या निकलेगा? FSH LH. किसी भी लेवल पे मसला हो तो आपका काम खराब, एमेनोरिया हो सकता है. सो नाउ लेट्स टॉक अबाउट कि पिट्यूटरी में क्या क्या गड़बड़ हो सकती है. सो पिट्यूटरी में कोई ट्यूमर हो सकता है, नेक्रोसिस बिकॉज ऑफ शीहैन सिंड्रोम, दैट्स बिकॉज ऑफ प्रेगनेंसी. इंक्रीज होता है साइज, फिर उसमें नेक्रोसिस हो जाती है. आइट्रोजेनिक डैमेज, कोई सर्जरी कर रहे थे, पिट्यूटरी डैमेज कर दिया, और कोई कॉन्जेनाइटल पिट्यूटरी डेवलपमेंट में इशू था. सो ऑल दिस कैन हैव पिट्यूटरी प्रॉब्लम, एंड इफ पिट्यूटरी प्रॉब्लम स्टक, याद है ना साइकिल बार बार, हाइपोथैलेमो pituitary ovarian axis. So hypothalamus के प्रॉब्लम, पिट्यूटरी की प्रॉब्लम, एंड नाउ ओवरी के प्रॉब्लम. जैसे मैंने आपको बताया ना, ओवरी के भी प्रॉब्लम्स होंगे तो मेंस्ट्रुअल साइकिल नहीं होगा. सो फॉर एग्जांपल टर्नर सिंड्रोम या पॉलीसिस्टिक ओवेरियन डिजीज, इसके बारे में भी हम बात करेंगे थोड़ी देर में. इट इज गेटिंग वेरी वेरी कॉमन. Also, if there are endometrial problems, so endometrial problems can also lead to absence of menstrual cycle. So primary amenorrhea may result from Mullerian defect. अगर यूट्रस डेवलप ही ठीक नहीं हुई तो मेंसेस भी नहीं होंगे. So that's a simple concept, right? Now, investigation of amenorrhea and oligomenorrhea. If patient comes to you, okay, Dr. Saab, I've never had bleeding, primary amenorrhea or even secondary, what would you do? So obviously history taking and general physical examination, and then you move on to the laboratory findings, such as you must do SH, FSH and LH levels, testosterone levels, and you should be then making a diagnosis based on if LH or FS, for example, are not there, then it can be a problem with the pituitary and things like that, right? Raised LH, luteinizing or raised testosterone could actually suggest polycystic ovarian disease. Raised FSH may also suggest POF. अभी हम इनके बारे में डिस्कस करते हैं. I will spend some time talking about POF and PCOS. POF, by the way, is premature ovarian failure. A raised prolactin level may indicate prolactinoma, which is a tumor. So maybe pituitary is not producing enough FSH or LH. Thyroid function test should be done. You should also do imaging, such as MRI, to see if there is any tumor in the pituitary or hypothalamus, such as pituitary adenoma. Hysteroscopy is not routine, but you may require it to see if everything in the internal genitalia is fine. You may also require karyotyping if you are suspecting Turner. So ये सारी investigations हैं जो आप करेंगे if the patient comes to you with oligomenorrhea या amenorrhea. Okay, right. So management would be, they say they have outlined this in table 3. So let's have a look. So you basically knock out the cause. If you are dealing with a person with low BMI, deal with the BMI. If there is hypothalamic problem and glioma, do the surgery. If there is pituitary tumor, do the surgery. If there is premature ovarian failure, you start appropriate therapy such as hormonal replacement therapy or combined oral contraceptives. If there is polycystic ovarian, you do relevant drugs to increase ovulation and control the hormonal status. If this is Asherman syndrome, you deal with an IUD, intrauterine device insertion, when you are doing hysteroscopy. So depending upon what your diagnosis is, the management differ. Okay. Also, if we look at this particular, so if you are dealing with the patient with amenorrhea, what are the key points to pick up during history and examination? So for example, if there is developmental history including menarche, this is the information that you need कि menarche time पर था, delayed था, developmentally यानी कोई चीज़ report की थी पैदाइश के वक्त, birth के वक्त, so कोई puberty में कोई issue था. So these are the information that you need so that you can make a diagnosis of a congenital malformation. आप menstrual history लेंगे, reproductive history अगर available है, symptoms, if there's a hair growth, so for example if there is hirsutism, then you suspect increased problem within the ovary, PCOS. How is the weight looking like? Is increased weight or decreased weight, things like that. Particularly if a person tells you, I've been trying to lose weight with all sincerity, but then it's still not going. So polycystic, maybe the effects of steroids. lifestyle. So a lot of things that you have to catch during the history. I'm not going into the details because we did that in chapter number 2. A good history gives you a perfect diagnosis. Now, I think I will spend some time on a very important topic, which is polycystic ovarian syndrome. PCOS is a syndrome which is basically affecting the ovaries. There is an ovarian dysfunction along with cardinal features of hyperandrogenism, so more androgens, and also polycystic ovary morphology. So ovary there will be multiple cysts. Okay, that's how you remember the terminology. If you look at the ultrasound, it's a transvaginal ultrasound. You see different cystic lesions here. You see actually here in the gross phenotype as well. Okay, and the metabolic symptoms are that of hyperandrogenism. The prevalence of PCOS seen on the ultrasound is around 25% in all women, but I've read some recent research. It has actually increased because of the dietary patterns. Clinical manifestation include menstrual irregularities, signs of androgen excess, hirsutism, and acne, and also obesity. So ये सारी चीजें जो हैं मिलके they constitute the syndrome PCOS. Elevated serum LH levels, biochemical evidence of hyperandrogenism, and raised insulin resistance, they're all features of this syndrome. PCOS is associated with an increased risk of type 2 diabetes also, and also cardiovascular events. Okay, and it's not completely clear why this happens. There are so many factors. There are genetic factors, dietary factors, environmental factors, which can contribute to PCOS development. Clinically, there is either amenorrhea, complete absence, or oligomenorrhea in most of the patients. And there is hirsutism, increased hair all over the body, and subfertility in many of the females, 75%, big number. Obesity is also present in roughly half of the patient, and skin pigmentation is increased, which is what we call acanthosis nigricans, particularly in axilla and other parts of the body where there are flexing curves. However, very rarely the disease can be asymptomatic, but usually obesity, acanthosis, these things are hirsutism, they are present. Okay, so diagnosis wise, if you have to diagnose PCOS, amenorrhea is an important clinical feature. Androgens increased is diagnostic, and polycystic ovaries, so they constitute the diagnosis, right? If these three features are there, you diagnose PCOS. Okay, how do you manage these patients? You manage them at multiple fronts actually. So oral contraceptives are used. This is for regulation of menstruation. It also increases sex hormone binding globulins, which will help reduce the androgenic symptoms, so hirsutism goes away. Cyclical oral progesterone is used to regulate a withdrawal bleed. So if you withdraw the drugs, the bleed is controlled by progesterone. Clomiphene is important because it adds to ovulation and it improves the fertility. And obviously lifestyle advice, some more exercise, dietary changes, taking care of the cardiovascular stuff, some aerobic exercises, weight reduction. Ovarian drilling is a invasive procedure, so it destroys some of the ovarian stroma so that the cysts are basically destroyed. Okay, so जो anovulatory cycles हैं, they turn into ovulatory cycles. Treatment of hirsutism and androgenic symptoms. So this was all to control the hormonal stuff and now the hirsutism. So once this is basically controlled, then these symptoms also improved. But topical treatments such as eflornithine cream and some other creams, metformin for insulin resistance, and GnRH analogs. Basically, what you want to do is you revert the androgen excess and you want to produce a rhythm for the menstrual cycle. So contraceptives, combined oral contraceptives, and all these combinations along with the lifestyle modifications are all very important for controlling PCOS. So premenstrual syndrome क्या चीज है? It's a cyclical, somatic, psychological and emotional symptom that occur during the premenstrual phase, luteal phase में, यानी ovulation के बाद day 14 से लेके around day 28 तक, right, something like that, they start having these symptoms. So these symptoms can be sometimes just not present, sometimes they are moderate, sometimes they are very, very severe. Okay, etiology is unknown. In some females this happen, in some females this just do not happen, and the patient is likely to complain of these: bloating, weight gain, mastalgia. They start having like muscle pain, sometimes Also pain in their mammary glands, headache, fatigue, depression, irritability. These are all important features of premenstrual syndrome. And how do you manage them? You manage, well, if this is identified, then obviously you have to manage them, right? Simple therapies may include try to reduce the stress, try to basically exercise also improves it. Do whatever elevates your mood. That's the kind of thing, right? Remove from your schedules caffeine and alcohol, particularly during those days. Okay, so these are simple therapies, lifestyle modification type of thing, but sometimes you need medical therapy. Combined oral contraceptives are the magic pills. Transdermal estrogen some people use. SSRIs are good. They improve big time premenstrual syndrome. And also gonadotropin releasing hormone analogs, they because they kind of try to shut off the ovarian activity. These are kind of going too far away. Hysterectomy, well, I do not recommend such things unless really required. Some vitamins, some alternative therapies such as cognitive behavioral therapy. These are all psychological things. Behavioral therapies have been used very, very effectively, because in some females, actually, this is a big time problem. Every menstrual cycle, imagine, right from the age of 13 or 14, with, puberty starts, say, with every menstrual cycle, they start like pain and, mood behaviors changes and mood swings and all these things, irritability. So they really need treatment. Okay, so that's what it is. Now ये एक लंबा चौड़ा सा यहाँ पे चार्ट दिया हुआ है. Mild to moderate premenstrual syndrome, encourage lifestyle changes, stress management, some mild therapies, perhaps some vitamins. But if there is moderate to severe, think about some medical intervention. Okay, you may need to use some antidepressants, for example, contraceptive pills. And if it is absolutely resistant and it is really, really there, you may need to, at the end, as a last resort, do some surgical intervention, which is severe. See, hysterectomy, bilateral self-ping. Oh my God. I wish no patient received this surgical treatment for premenstrual syndrome. But because cases exist, that's why they are in the textbook. Okay. So that's basically it. There are some key learning points. We talked about the hypothalamic-pituitary-ovarian axis. We talked about puberty and regular menstrual cycles, some disorders of chromosomal stuff, developmental disorders. PCOS is important, and premenstrual syndrome is a real deal in some females. Few case histories. A 22-year-old woman approached her GP complaining of irregular periods, excess facial hair. I'm already thinking about PCOS, and some spots. She had increased her weight by 5 kg. Examination was not remarkable. BMI is raised at 30. What additional features would you like to seek? So seek all the features we discussed in PCOS. Okay, and investigation bhi jo maine batayi thi, and then the management. So this is a typical case of PCOS. You should rule that out. Menstruation, shedding. Okay, now menstruation is the shedding of dead endometrium. Which of the following facts are correct? During menstruation, the stratum basalis is shed. That is not true. During menstruation, stratum compactum is shed. During menstruation, fibrinolysis is enhanced. Endometrial regeneration begins after ovulation. That is not true. Regeneration happens immediately after menstruation. In fact, ovulation ke baad to, there is a lot of decidua formation, increased blood supply. It gets prepared for pregnancy. Vasodilation of spiral arterioles precede menstruation. Not really. Constriction happens. So prior to menstruation, vasoconstriction of the spiral arterioles occur, causing ischemia, right? The stratum basalis remain, everything compactum is shed. So B is the right answer. They're asking for the correct fact. This is the only one, right? Now, with regards to PCOS, which of the following statement is true? It is unusual cause of no, it is a usual cause of, actually it's a common cause of anovulation. Ultrasonic evidence of polycystic is present in 50% of the women. No. Roughly around 25%. PCOS is associated with obesity in 10%. Na ji na, obesity zyada females mein dikhti hai, roughly half of the females. PCOS is associated with acanthosis nigricans. This is absolutely true. This is true. That in the flexure folds, darkening of the epithelium. The diagnosis of PCOS could only be made by biochemical evidence. No. There are clinical features and there are biochemical. So the only correct answer here is D. Okay. So that's all about this chapter, and I will see you in the next chapter very soon. So all the very best till I see you next.